So, Dr. Jeremy Horst is the Director of Clinical Innovation at CareQuest Innovation Partners, an organization whose mission is to improve oral health for all by advancing innovation to transform oral health access and outcomes for underserved populations across the U.S. As a practicing pediatric dentist, biochemist, and educator, Jeremy is known for investigating the strengths and limitations of silver fluoride therapy, helping to develop smart fillings and accelerate the adoption of maximally effective, minimally invasive caries management techniques. In support of this work, Jeremy holds affiliations with the University of Washington Department of Oral Health Sciences and the Dental Therapy Program. At CareQuest, Jeremy is driving the development of better treatments, preventatives, and diagnostics to improve access to person-centered care, integrate oral health into overall health, and to stop dental caries. Help me in joining and welcoming Dr. Horst.
What a treat to be with you. Can you hear me? Wonderful. All right, everyone. I wish I was there in person with you, and I thank you so much for letting me join you and for your attention. Just want to say, in terms of innovation and access to rural oral health care, rural dentistry, that is a big focus of CareQuest and CareQuest Innovation Partners, of which I'm an employee. We are hoping to support expanded access and not restricted access from all of the consolidation of dental clinics into DSOs that we're all seeing and experiencing, and also expansion specifically of FQHCs and other public access clinic models. I certainly personally, and I am driving sort of the clinical philosophy of this institute. I believe that some of the things that I'm going to talk about today in terms of tools to manage the mischief of the oral microbiome can be used in a different type of clinic setting than we've seen before. Classically, there's been dental clinics and then outreach in schools and nursing homes, usually by hygienists, sometimes by dentists. And I think we can have an in-between model where there's a really scaled down, simplified dental clinic where you don't have to have 2,000 patients to make it make financial sense to have it there. That you can have a front office type, one chair clinic in a rural setting where dentists and or hygienists go 1 day a week, 2 days a week, 3 days a week, depending on the size of the population. And it's not a lot of the fancier, complex dentistry, but it's some of the simpler brush on disease management, counseling. And we are working hard to figure out payment strategies that Medicaid, Delta, all the private insurances would have used to make that make sense for everybody, even if it is with the DSO. So just wanted to put that out there that we are very focused on access to care issues and using the technology, the advancements that we're all seeing come through to drive that forward. Hopefully that's useful. So Dr. Nathan Suter asked me to share with you guys a little bit about the oral microbiome. I'm a pediatric dentist practicing really at the margin of sort of rural. I live in San Francisco. I was born and raised in San Francisco, and I drive about an hour to the edge of the last sort of 10,000 person city, going north to Northern California. And some of my patients are homesteaders. Some of my patients, hunt the only meat that they eat. A lot of my patients have farms, vineyards, all of that kind of thing. So it is a sort of a rural perspective for oral health and children focused that I largely have. That said, I've been in dentistry for 21 years, and half of that time has been pediatric, half of that time has been adult focused. So hopefully I'll be able to provide a useful perspective for you on dental plaque composition and how it relates to practical dentistry. So if we look at why cavities happen, why do cavities happen? When I ask educated people this, or when I listen to what they say to young children, it's a lot about not brushing. You got a cavity? Oh, you didn't brush your teeth often enough. And I hear the story that, you know, fillings stop cavities and then you're good. So that's the solution. That's the definitive treatment for cavities is a filling. And unfortunately, you know, we've kind of been hosed with this story, and those of us who sort of grew up with it, which is probably everybody, those of us who grew up with this story as dental professionals, you know, come to face the reality of what happens after we place fillings, after we ask people to figure out how to brush more frequently or floss more frequently, that they still get cavities, that cavities recur. Most of them last at least 5 years. But in the dental Medicaid space, most of them don't last 6 years, to just give a sense of that. For young children who go under general anesthesia to receive, you know, comprehensive definitive treatment, over 70% of those kids have another cavity, a cavitated caries lesion, a hole in their tooth within 1 year. So we need to do better. We can do better. I would say that, you know, there's many practices that have extremely high success rates that are really profound. I think we that are focused on public health would really do well to learn more and more from private practice operations that have extremely high success rates, and vice versa, that we need to learn from our successes because they are out there. But in particular, what we've been doing for trying to manage this disease with a brush and a drill and a string isn't sufficient to manage this most common disease in humans, most common reason for kids to be out of school, most common reasons for kids to go under general anesthesia. The third most common reason for an adult to go to the emergency department. So hopefully this will be useful, and that's the perspective that I bring. Just to tell you guys all something that you already know, but maybe from a slightly different angle. You know, how does caries actually happen? What's the enormity of evidence teach us about what the dynamics really are? So you got to start with teeth, right? No teeth, no cavities. You get plaque bacteria or your oral microbiota. You feed them sugar, and that helps them to grow, get more sticky, expand. It shifts who they are, what they do. And you keep feeding them sugar, and they make acid, right? And acid dissolves the tooth. Those are the dynamics that we are all taught in our dental training programs, and it's true. But we're missing some pieces. And what I'd say is that a lot of you, I'm sure, are already thinking, you're missing saliva. You got to have saliva as part of the dynamics, right? Saliva buffers the acid. It also controls the formation of the dental plaque. And then this is the story that those of us who have really paid attention know, that there's saliva balances these things. It also clears the sugars. It helps to facilitate the plaque formation. And that's it, right? Well, I spent about 8 years in one of the world's most advanced infectious disease biochemistry laboratories. It's the lab that discovered SARS-CoV-1 and created the technology that we all use to monitor SARS-CoV-2, you know, the Rona. And so there was a lot of data that we generated, a lot of questions that we were able to ask about dental caries, about what's going on with the plaque bacteria that makes them cause problems in these folks, but not these folks, etc. And to my shock, what I ended up with was a focus on food, was a focus on nutrition. That real nutrition, real food, traditional foods that all of our ancestors ate, balances and informs the health of our mouths enormously for cavities, more than anything. That healthy, good foods displace sugars. Healthy, good foods not only template a healthy dental plaque, but can actually restore the health of a dental plaque, as I'll mention. It buffers the acid and in fundamental ways drives the health of the saliva itself. So I hope to share that with you over the next 40 minutes or so, about how that works, what's going on there, what the story is, the data that drives that story, and what the specific tools that we can use are what are the specific tools that we can use to help guide individuals and families and communities towards a healthy mouth, largely through, but some other things, some antimicrobials that we have, but largely through a shift in nutrition by understanding the dental plaque in particular. And my thesis here is that cavities are caused by sugar, and it is a dental plaque disease. It is a disease of the dental plaque itself. So let's get into that. So first off, sugar. So if you look across history where we have good data, and this tends to be Europe for better or worse, there were cavities. You hear all these stories, oh, cavities have been around forever, for 10,000 years. As soon as we started processing grains into sort of processed carbohydrates, you started to see cavities. It was pretty rare though. It was pretty uncommon and small and not a huge problem. You have to work hard to find the skull from 1000 BC that had a cavity in it. And it turns out that once slavery started in the Americas, and that you had the abundance of workforce, of human power to produce a bunch of sugar and ship it back to Europe, then you start to see this huge spike in cavities. And we see this other places in the world. So this is a map of Japanese data of actual supplement of sugar to children in school, where they're estimating the total consumption of sugar per person per year in kilograms. And they're showing that, and I'll have you know, this is the logarithm. So this is, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then 20 and 30, 40, that there's this relationship, so there's this log relationship, an exponential curve of sugar to cavities. We don't see this with anything else. We don't see this kind of relationship inversely with fluoride. We don't see this with frequency of brushing. We don't see this with flossing. The only thing we see this with is sugar, and we see it across the world. To relate this to the American diet, the end of the scale here is 15 kilograms per kid per year. The average American diet today is 60 kilograms of sugar per kid per year. And so it's amazing how well our preventives, such as brushing with fluoride toothpaste, the flossing, and all the things we do, work in the context of this data, that we don't see 15 new cavities a year per kid, or 4 times that amount. So a lot of our work is working, but the sugar is really driving this. Now, last sugar slide, I promise, is just to say that it takes time. So this is related data from Japan, different population within Japan, but this is more sugar this way, more cavities vertically. But what you see on this sort of left axis is the time since the tooth came into the mouth. And these are all permanent teeth. And so the average time since the tooth came into the mouth, you have to, these things take time. And as humans, it's hard for us to operate on this time scale, to think, okay, they've been having 5 kilograms of supplemented sugar in their diets at school. And then 3 years later, 4 years later, 5 years later, 6 years later, they're having this, 40 cavities per 1,000 teeth, and so on. So sort of lessons of that this disease works over time, and that the cause has been established for a long time, and it's not brushing. To give a sense of where we are with consumption of sugar and ultra-processed carbohydrates, ultra-processed diets in general, to think maybe beyond the sugar and to whether we might be missing other parts of our nutrition. The average child in the United States has 2/3, that's 67% that you probably can't see, 2/3 of their total their total calories per year is from ultra-processed food. So food that's made in a factory and that doesn't grow from the ground. 2/3 the caloric intake of children in the United States on average is crackers and things like that. So this is a problem. About 80 years ago, there was this book published, which was sort of a worldwide survey by Weston and Florence Price, this dentist, I think from Michigan, who just saw that everybody in the cities had cavities, and people who tended to live in their traditional ways didn't have cavities. And so they went across the world for 10 years and just looked at the end of the trade routes where processed food was going, and looked in the schools and in the work sites, and then went out into the bush 20 miles, 30 miles, 100 miles, and visited the villages where people were living on their traditional foods, and found plenty of places that would answer all of the questions that we would ask as exceptions. Have they never encountered anyone Western before who could have infected them with their bacteria? And they'd look and find places where there was a man who married in, a white man who married into the culture or whatever. They went all over the world, and they found this perfect relationship of cavities and no cavities based on these foods. And so the conclusion, as I'll get to it there, is that the plaque that drives the composition of the oral microbiome that drives this disease is first selected for and then driven by the nutrients or lack thereof. We'll get further into that detail. And so what we see in some of the most advanced public health clinics in the country, some of these are IHS clinics, some of these are affiliated with Harvard and fancy things like that, is that they are taking a whole footprint of a whole clinic space for their new clinic sites and putting in a teaching kitchen where doctors and dentists prescribe people to come in and make meals together to learn how to make real food, because so many people have lost touch with how their ancestors made food. Even the grandmothers, they were displaced, they moved, they worked really hard to get good jobs, and they never really paid attention to how to actually cook. So they eat fast food all the time or whatever it is. This is the reality that's driving diabetes, obesity, heart disease, stroke, some cancers, definitely cavities, perhaps periodontal disease, is the food. And so this is not some fringe idea. This is what the advanced public health clinics across the country are starting to do, is put in teaching kitchens where we can all relearn how to cook and eat well together. And believe me, I'm very shocked to be saying that, because I was looking for a drug to treat cavities, and designer drug, whatever, across the last 10 years of my career, and I found that it's in the nutrients already. So I've been talking about food and sugar for an oral microbiome talk. What are you doing, Jeremy? Is this clinically important? Absolutely. So let's talk about that and how we know, why we know what that's about. Xylitol. The reason that we know that the dental plaque composition is important for cavities is because of xylitol. And it's not using xylitol chewing gum for yourself as an adult or as a school-age child. It's giving xylitol gum to new mothers after their child is born. New mothers who have cavities themselves, who have a problem with cavities themselves, who have high strep mutans levels, and you give them xylitol gum, and this is the pink here, do nothing different with their children, and their kids get less and less and less colonization with strep mutans. So there's something about the way that the xylitol gum in the mother's mouth, the mother's cavity-ridden mouth, changes the way that the child picks up strep mutans or not. It doesn't come out in the breast milk. This has been done with women who don't nurse at all, with women who totally nurse. And we see this happening over and over again, that there's a delay or a dramatic decrease. There's been 63 published clinical trials looking at strep mutans colonization in children now across 5 continents, and it's all the same result. You chew non-xylitol gum, chew xylitol gum, you see this difference in strep mutans accumulation in this really interesting way. So the concept here is that we have this life cycle transmission of dental plaque, that we have this window of infectivity when we're kids. As our teeth are coming in, there's a new ecological habitat, there's a new environment that's native and there. There's a new place for bacteria and yeast and all the microbes to come and inhabit. Just like if you were walking around with a petri dish. I'm a microbiologist. I think about, all right, if you open a petri dish, you will get bugs, right? Tooth comes out into the mouth, it's going to get bugs. And so the concept here is that whoever they're around, which historically was their young, healthy parents, and these days tends to be more and more, loving way, older and older grandparents who may have cavity problems coming back themselves because of lots of medications driving their saliva down and the natural process of aging. So what we see is that the bacteria comes from whoever the child is around the most, and if that person has cavity problems themselves, those bacteria are going to be differentially selected for in the kids. So to intervene in this with xylitol gum in the person who is caring for the young person, and the elder or parent or caregiver or school teacher who has cavities themselves, to prevent passage down of these bad bugs, can be profoundly effective. Now, what I told you about was outcomes with strep mutans. Who cares about strep mutans, right? What we care about is cavities and pain and suffering. So if you actually look at the studies that have reviewed cavity formation, not strep mutans formation, it's even more profound in its effect. So when you give these new mothers, new postpartum mothers, 3 months out after birth, enough gum to chew for a year, 2 to 3 times a day, enough that they get about 8 grams of xylitol, their kids have like 75% less cavities when they're 5. They never did anything different with the kids. The only thing that explains this is a difference in passage of strep mutans and other similar karyogenic bacteria. And this has been replicated over and over again. There's actually like 7 studies now, but this is what I published 4 years ago. But whenever people actually look at cavities, they get the same result, that giving mothers chewing gum, xylitol chewing gum. So you can do this with grandparents, right? I'm very blessed that my father was retired when my children were born, and he spent a day a week with them. He's a long-term sufferer of cavities. It's we've been working on it together for a long time. He likes sugar. So I have a little jar of xylitol gum that's up high so the dog doesn't get it, that he chews when he's around my kids. No cavities, 6, 4, and 2 years old, no cavities. Do I brush their teeth twice a day? I don't think I've ever brushed their teeth twice a day. Do I brush them every day? Probably. Do they have healthy plaque around them? Yes. So accordingly, share the healthy plaque. We've had this for about 20 years now. We've had this story of, don't kiss your baby on the mouth, don't share a spoon with your baby. Well, so we do need to be careful of sharing bacteria from parents who have cavities to young children. But if you have a healthy mouth, if you've cultivated a healthy oral microbiome for your adult life, and now you're having children, and you haven't had cavities in 10 years, you should take your plaque and smear it over all the kids that are playing with your kids to help prevent cavities. Seriously, it's like that weird classic thing that the president kisses babies. It's like successful, healthy people that are at the pinnacle of our society, and maybe that's the president, maybe it's not. Classically, in prehistory, would kiss the babies. And part of that is sharing, a fundamental part of that is sharing our oral microbiota from someone who is healthy to someone who is forming early on. And there appears to be this window of infectivity, as I sort of mentioned earlier, that when the teeth first come in, at some point thereafter, you start first seeing bad bacteria like strep mutans. Now, in other populations that have worse disease rates than where this study was done, so it's done in inner city New York, where the first cavities show up around 2.5, 3 years old. Basically 6 months after the strep A10 shows up. Plenty of other communities have their window of infectivity much earlier, especially in Indian country where I go out to a lot. And so in each community, there's this window of infectivity for young children that will be different per community, per family. That depends on when the teeth first come in and how bad the bacteria are in the community. And we can precede this by modulating how the oral plaque is passed down with things like xylitol gum. If you've ever seen the Stefan curve, this is kind of the so what. This is the key mediator of sugar into acid over time is differences in plaque. And so what Robert Stefan figured out, what is that, 70 years ago, 77 years ago, is that different people who have had a different history of cavities, with the group 5, the V down here, being the most cavities. They have, I think it was like 6 cavitated lesions in the mouth at that time. They have a different oral plaque composition. They have a different salivary function, and these two are related, which we'll get to. And that if you give them the same glucose rinse or same sucrose rinse, same sugar rinse in their mouth, that within a minute or 3 after, in the plaque itself, you'll see a pH drop and then a slow recovery over 30 minutes, 60 minutes back to the baseline. And the resting pH will be different. And so it is the plaque that mediates this difference. It's the composition of plaque that mediates this difference. And of course, the pink line is that critical pH of about 5.5, 5.3, at which enamel loses its mineral, demineralizes when it is hydroxyapatite. Of course, it's a little lower for fluoroapatite, which is why it's so protective. So this oral microbiome thing, what is it? What does it do? Like, how does it work? That's our next stage. Well, as we've mentioned, not all plaque is the same. Unfortunately, it's not just on a spectrum. It's not just on one axis of good, not, kind of good, neutral, kind of bad, terrible. It's not that. It's sort of infinitely spaced out. So using the same color scheme in these different 4 pictures of plaque that's scooped out of a person's mouth, you can see that the colors are different in each of these. The distribution of the colors are different in each. And so not only are the species that you see different, in general, if you go species, genus, in general, the genus level is similar. But the species tends to be really different in terms of distribution and what that particular species can do, and it's a whole different thing. But the relationship of the different plaque bacteria to each other 3-dimensionally and physiologically is quite different, sort of from person to person, and even within our own mouths. We know this. We know that the lower front teeth, the upper front teeth are much less likely to get a cavity than between the back 2 teeth. And between the back teeth, we're much more likely to get perio disease. There are simple anatomic factors that describe this, but the bacteria follow those anatomic factors by physiology. And we can see this now that we're able to take these beautiful pictures of dental plaque. So this is, yet another recent sort of study of it's a review, but a recent study of dental plaque. And this is just shared to emphasize that there's a lot of confusing words around what's biofilm, what's plaque, whatever. Everybody seems to have their own definition. But the sticky stuff between the bacteria is really important, and we'll get to that. Yeah, so there's more and more pretty pictures that help us to understand more of what's going on and more understanding of how the different genuses of bacteria can relate to each other. And so if you're a fan of this kind of thing, then start getting familiar with basically these 7 words. They're genuses of dental plaque bacteria that are kind of the story going forward for caries. As Neutropia, Streptococcus, Veillonella, sort of the Streptococcus and the Veillonella, and the balance of those two overall kind of predicts caries. Haemophilus is also overlaps with the species of Agretibacter, like aggregate, likes to make plaque. Prevotella rothia is one that's emerged in the last 10 years, and capnocytophagia also. So those are, if you want to become a fan of this, or if you already are, those are kind of the big seven for caries. And we see them showing up and see their architecture in different ways. So that was a 2020 paper, 2018 paper. We've known since before 2004 that these relationships are complex, and that there's specific bacteria that can grab onto other specific bacteria. And so how we think about it is that basically there's certain bacteria, usually Streptococci, that can grab directly onto the enamel pellicle. So the enamel pellicle is secreted by the saliva. It's just these little peptides, these tiny little peptides that grab onto the enamel directly. And then they sort of all have this part of them that hangs off that the Streptococci can grab onto. And if you have a really healthy saliva, it will produce a really healthy pellicle that will promote really healthy Streptococci grabbing on. And if you don't, and you eat lots of sugar, then Strep mutans is going to grab on. So that's kind of the gist of things, is that the mechanism of templating your dental plaque bacteria depends on healthy saliva producing a healthy pellicle that then healthy bacteria are around to be able to grab. And then you get this layering of bacteria on top of it. And if they're not, and you feed Strep mutan sugar, then it doesn't need the pellicle or anything else to grab onto the tooth. It and its bad friends can grab directly onto the tooth with their plaque. Let's just call it plaque for now. Extracellular polysaccharide matrix, whatever. This is another illustration of sort of what we all see every day in terms of plaque thickness, having really different properties. You know, you can look at plaque sometimes and just know that when you scrape it off or brush it off or whatever, you're going to see a cavity underneath it, or you're not. And so some of the core mechanisms of that are starting to be really clearly resolved. And so what I would call plaque, the EPS, extracellular polysaccharide, just the thickness of this as it gets down further and further into a more mature plaque down here, it creates an ecological niche. It creates an environment that is separable from the saliva, that's separable from the overall mouth. And the more isolated from the rest of the mouth the dental plaque gets, the more it can do nefarious things like keep the oxygen out so only certain bacteria can grow, drive the pH up so only certain bacteria can grow, produce more and more bacteriocins or mucosins. It's these natural antibiotics that bacteria produce to outcompete each other so that we can get really lots of strep mutans and other bad bugs deep at the heart of this plaque. So this is one of the reasons why oral hygiene is important, you know, every day, is that you don't let it get here, because then if you just feed the bacteria a little bit of bad stuff, they can shift the microbiota, they can shift the composition towards an unhealthy plaque by lots of these metabolic activities. This is another where we're specifically focusing on sort of what strep mutans can do within that story. It's overall just turned sideways and overall the same story. And I'll alert you to the strep mutans is the dark orange, I don't know, it looks like a little like old avocado to me or something, has little black lines around it. But if you kind of look out for this shape throughout the timeline, the story here, you can see that it goes from being sort of one of many, one of many, one of many, oh, and then it starts to outcompete as the plaque thickens, the plaque thickens, and it has all these really specific interactions to cross-compete with these other bugs, or is supported by other bugs like lactobacillus, bifidobacteria, scardovia, and Candida albicans. So all of these bacteria and this yeast They like acid. They like to outcompete other bugs by making lots of acid and tolerating lots of acid. So they work with each other. And it's now been determined that it's not just acid. There's also really specific physiologic and structural mechanisms that they use to support each other and get everybody else out. So, they form their clique and kick everybody else out onto the property, and it's just them that gets to hang out. And really the main driver of this, y'all know what sucrose is? Sugar. So that's where you really get this transformation, is when you have sort of a normal plaque, start feeding it lots of sugar frequently. The plaque thickens because strep mutans turns it into that extracellular polysaccharide matrix really quickly. That's so sticky. And then it sort of forms its house, it forms its bubble. And then all of these bugs, the Candida, the lactose, the bifidos, all the bugs that love acid, love low pH, they start working together to just kick everybody else out and create a really disease-causing, cavity-causing composition that then fed, once it gets to here, you feed a little sugar, or even not sucrose, but a little, crackers, and it'll turn into cavities very quickly. It'll turn into acid that demineralizes the tooth very quickly. So that's the overall story of our knowledge of plaque bacteria, and how the thickness of the plaque corresponds with the composition of the plaque when sucrose is around, and how it really transforms this shift, and why I spent so much time talking to you about sugar at the beginning of this conversation. Now we're going to throw a little bit of a stitch in that story. My apologies. So that overall, that story holds, but I just want to say it's a little more complex, and that, I think it's really important for the laboratory scientists to continue working on oral microbiome stuff so that they can inform us and come up with better tools, better therapeutics, preventive strategies, all that stuff to manage cavities. But in general, it's not a simple enough story to really deploy in all of our clinics right now, unfortunately. And believe me, I mean when I say unfortunately, I've done a lot of oral microbiome clinical research studies watching over years, and there's just, everybody is their own story, and there's not a cohesive story, as I will show here. So the top oral microbiome researchers in the world, over at the Forsyth Institute in Boston, conducted this study in 81 kids of what their relative proportion was of all these different bacteria, all these different species, whether they had severe early childhood caries or no signs of cavities at all. These are kindergartners or preschoolers, both. And so what you see is, yay, it fits the mold. There's twice as many strep mutans positive kids who have severe early childhood caries as who have no cavities. And there's like 3 times as many Scardovia wigsii in these kids versus the others. The problem is that 10% of kids with no cavities whatsoever have this Scardovia wigsii thing, and a third of kids with no cavities whatsoever have just as many strep mutans as the kids with severe early childhood caries. So we can't just test for those 1 bugs or 2 bugs and know that they're going to have a really high risk of caries. There's not a direct correspondence, unfortunately, like we have with sugar. To demonstrate this point, or really to ask this question, these are good scientists, so they know that you don't just go do 1 study, you do 2 studies, and you compare across different populations. So when they did basically this same exact study in the same county at a school down the street, 2 miles, 3 miles away, they got a vastly different result. So overall, the same assessment. If you look at strep mutans in both of the groups, it was around 1/6 of kids were positive for strep mutans at a relatively high level. Meaning that would be completely useless to look at whether kids were going to get cavities or not, or whether they're recovering from cavities or not in this population, unfortunately. So just the story here is that there's not a consistent story. Now, what if you look across the oral microbiome as a whole? Can we delineate a population that's causing cavities from a population that's not? And so that's where you get these weird scatter maps, and the scatter maps are trying to like simplify into a way that we can see the complexity of the whole profile of bacteria in someone's mouth. That takes into account the level of strep mutans, the level of, you know, all the different bugs. And and so if you take, same story, kids with no cavities, kids with severe early childhood cavities, and if you just culture them on a petri dish that's made sort of with this blood-based agar or this acid-based agar, there's drastically more similarities with which petri dish influences than the disease state of the child for the dental plaque composition. So the story here seems to be that it's just too complex to resolve with current technology that just looks at the genus level, or most of the time at the species level, and that we need sort of a better delineator of that. And we have some of that. And part of the problem, part of the difficulty is that in the United States, we have a very diverse population. You may think that, okay, it's not that diverse over here in this county in Boston where they did this study. It's mostly, you know, 60% white, 40% black, or whatever it is. But just the variation across white people, across black people, is tremendous when it comes to sort of our historical lineages of our dental plaque. And that's shown on the right here, that if you take kids with severe cavities from Sweden versus kids from versus Romania, the blue dots and the red dots, they separate vastly. You would expect to see a lot of similarity on these kinds of maps, and there's none. There's none. Using the current techniques that only look sort of at the species level. So part of the story is that we have to look deeper, and that if you take 5 strep mutans, you have 5 strep mutans, and they have different tricks and tools up their sleeves, and that's nothing compared to the lactobacilli. I looked at lactobacilli in the lab for like 3 years, and it was, oh my goodness, it was like 80% different over their genome across everything. They have all sorts of different tricks and tools and all that stuff. They're just very different. So someday we'll get there. But for right now, this is the story, is that we can't put Swedish kids with cavities together with Romanian kids with cavities because their plaque is so different. Finally, for sort of an emphasize point, anyone who has worked with American Indian and Alaska Native or First Nations children with their cavities knows that they have by far the worst cavities in the country as a whole, by and large, with lots of great exceptions. And so looking at the oral microbiome in this study here, by a group that's now at the Forsyth, was at USC at the time, their story was the same. This seemed like the lowest hanging fruit. You have severe early childhood caries with, you know, most of the population in this community going to general anesthesia for cavity treatment by the time before they go to kindergarten. And then you have a subset of the population in that same population that has no cavities whatsoever. Take their dental plaque, and what we see is that there's marginal differences in the level of strep mutans that overlap, and that you can sort of separate these guys out a little bit, but not perfectly. It's not like you're able to like look at the composition of their plaque and say these people are cavity people and these people are not cavity people. And if you look at this sort of this color chart, I like this color chart on the lower right. Overall, it kind of looks the same, right? And if you really spend time with it and look closely, what you'll see is there's a small bar for strep mutans in this lilac, you know, it's like the color of dentistry. It's like our favorite color, versus, you know, over here, and, you know, maybe that's what's driving it. And you have Neisseria sort of balancing that out. So you have a decrease in Neisseria, increase in strep mutans. Is that what causes cavities? It doesn't seem like it. It seems to be a mediator of cavities that follows the sugar and the malnutrition, the lack of support of our saliva, that mediates this story. So in conclusion, thus far, and there'll be another small section after this, sugar is converted in mature plaque to acid, which demineralizes the tooth. We all know that. But the highlight here is mature, is that it takes maturity of the plaque, which sugar drives, to demineralize the tooth. So if you brush your teeth all the time with no fluoride, brush and floss all the time, you're not going to get cavities because the plaque never gets mature. So that's one way to do it. It's not very realistic for most people. But the children of pediatric dentists are famous for not having very many cavities because we're always brushing and flossing their teeth, or at least my friends are. Sugar selects for karyogenic bacteria. In the laboratory, when we take a saliva sample or a plaque sample, and we try to isolate Streptococcus mutans, what we do is we make a petri dish with 15 to 20% sugar. The only thing that will grow in 15 to 20% sugar is strep mutans. And there's other things that, a couple, like 3, 4 other things that we use some other tricks to get rid of them. But if you look at, there's 700 species of bacteria in the mouth, and only 3 or 4 of them will grow that much sugar. The sugar itself has so much osmotic pressure, it pulls water out of bacteria, that the bacteria needs special mechanisms to overcome just the amount of sugar. Because that amount of sugar usually kills bacteria. But strep mutans and its bad friends thrive in those conditions. So it's the same thing in our mouths. Having high levels of sugar, just like the petri dish, selects for the bad bacteria that have mechanisms that can tolerate that amount of sugar and the acid that the bacteria produce from it. Next, infinite microbial compositions can facilitate caries. What does that mean? That means that there's a wide array of different populations of cavity bugs, of dental plaque bugs, that can result in cavities. There's no one axis that's worse or better, unfortunately. It'd be nice if it were. And fed sugar and ultra-processed carbohydrates like crackers, the plaque will progressively become more karyogenic. You'll have a shifting in the dental plaque composition, not a huge profound one, but enough that the bad bugs will overcome. Not a profound shift in the mouth as a whole, but in those specific niche areas, the plaque on the teeth, then it shifts quite a bit. Karyogenic bacteria are really good at getting passed down from mother to child, from grandfather to child, from their environment between siblings, when children are young enough that their teeth are coming in anew. And this story relates pretty clearly to newly exposed roots. That's a new ecological niche that's being exposed to the world. And so it's very easy for dental plaque bacteria to go jump on there right away. Now we have some antibiotics and prebiotics that are emerging as clinically useful for caries. So that's how we will wrap up. One key prebiotic that we just talked about, what's a prebiotic? Xylitol. What is xylitol doing that giving it to a mother 2, 3, 4 times a day from when her baby is 3 months old to 15 months old that year? What is it doing that it shifts the bacteria so fundamentally in her kid that they get less cavities? Well, it turns out that it's making it really hard for strep mutans to do its thing. Those bacteria are really indiscriminate about anything that looks like sugar. Xylitol looks like sugar to them. More judicious, careful, church-going bacteria don't get fooled by xylitol. They don't take it up, and they can get passed down. So that's an example of a prebiotic determining what bacteria come out of mom's mouth and land in the kid. Well, are there any other drugs against these bugs? Antibiotics, prebiotics, this is what we're going to talk about. Now, we already talked about xylitol gum for new moms. You've probably heard stories about silver diamine fluoride enough times that I won't bore you again. It's sort of revolutionary for me to give a talk that doesn't include a big focus on silver fluoride. So hopefully that's all right with you. And then we'll talk a little bit about povidone iodine. And this will be relatively quick to hopefully expedite your session. Arginine toothpaste. Has anybody heard of arginine toothpaste? I wish I was there with you so I could. It turns out that there's toothpaste all over the world, kind of except the United States, that has arginine in it. Arginine is an amino acid. It's one of the 20 core amino acids that all of our proteins are made of, that we need as a nutrient, that we eat in food every day if you're eating remotely healthy food. And it turns out that there's major metabolic pathways in bacteria to use arginine. And so it generates alkali. What does that mean? It increases the pH. If you feed dental plaque bacteria arginine, they will raise the pH from 6, from 4, from whatever it is, up to like 10. And that it shifts their metabolic function. They don't just raise the pH, they shift what they're doing in a really fundamental way. So we know that low pH, driven by sugar being, you take dental plaque, feed it sugar, low pH, just like that can be used by acid-loving bacteria, sugar-loving bacteria, to outcompete and drive away bugs. And so they can overcome and cause cavities. Arginine can be fed to dental plaque, and different bacteria will increase the pH, overall usually around 7.8, 8, but as high as 10 in a short time, to outcompete the acid-loving bugs and just build a higher pH loving set of bacteria that doesn't produce acid because they don't like acid. So that's sort of the fundamental mechanism there. This has been tested in microbiome work, where they've done a clinical trial. They've separated out caries-free from caries-active patients and looked to see that their strep mutans to strep salivarius, or a bad bacteria to good bacteria ratio, is different at the beginning of the study in the caries-active folks, and that it resolves, that it shifts down. The level of strep mutans, when it's there, it shifts down back to a relatively healthy state after the arginine toothpaste every day. So the mechanisms are there that this is also a prebiotic. It's not directly killing any bugs, but it is empowering bugs that don't cause cavities to thrive. Now, is there clinical evidence on this? So sorry, there's no pretty charts, but basically there's been 3 gigantic clinical trials in school-age children. You can see the ages here, how many kids here, the percentage of arginine in the toothpaste. And it's the rest of the world has this arginine and fluoride toothpaste from Colgate, and then just normal fluoride toothpaste. So comparing, there's basically 16.5 to 19% less cavities when you just add a little arginine in the toothpaste. Now, is this safe? Arginine is, you have to eat arginine to live. Your bacteria can make it, you can eat it, depending on your fluoride, you need arginine to live. So this is very healthy, this is fine. If you've ever seen muscle milk, it's like 40% arginine, which is one of the reasons, and for various other reasons, the muscle milk, the muscle bodybuilders, they don't have cavities, they have perio disease, because other things in the muscle milk drives calculus formation. And then in elders, in smaller studies, but 300 is a big study for dentistry, roughly the same outcome in older adults, just by adding this to the toothpaste. So that's pretty exciting. There's an additive effect on top of fluoride toothpaste. And right now, as we speak, there is a phase 3 clinical trial going on in the United States comparing fluoride toothpaste to arginine toothpaste, specifically because we have such a growing portion of the population that says no to fluoride. So folks want to be able to provide something that works instead of all these, coconut oil, whatever, toothpaste. And so there's a phase 3 trial going on right now in the United States comparing fluoride to arginine. So I would guess that in 3 years, we're going to have a whole line of arginine toothpastes, and hopefully we'll have a combination that will really be effective. And again, it does this by changing the flora. In the United States right now, there's one product that has a substantial amount of arginine, actually has 8%. It doesn't have fluoride, but Tom's Rapid Relief has it. I have no money in the product. Finally, my favorite new topic, it's an old topic, it's a new topic, what is it? Is iodine. Iodine? Betadine. Just the same stuff you have in your medicine cabinet that you put on wounds to prevent them from getting infected. That stuff that's brownish orange when you paint it on the skin. We can put it on teeth, and that prevents cavities. How does that happen, you ask? Oh, glad you asked, good question. It shifts the microbiome to a healthy state. So this is another one of those maps where, okay, we can sort of tease out roughly the people with cavities are in the blue circles. The people without cavities are the triangles, the white triangles. They're kind of separate at the beginning. And then after iodine, it sort of shifts to a more, roughly more healthy state, we think. At least shifts it, at least changes it. Is this super convincing? I don't know. Let's look at the evidence, right? And where this comes from. So again, I'm literally saying to use like any of the over-the-counter betadine, povidone iodine, 10% on your teeth. Right now, what we have is a cotton swab. I'm working with a couple companies, no money in it, to provide to create dental products. Elevate in particular looks like they're going to come out with one this year, where you have a dosed dental device to apply the iodine. But for now, there's like, I don't know, 100 products on the market. They all work. So this has a long history in research, where basically it's been about 50 years that specific microbiology has been done, looking at the effect of iodine on cavity-causing bacteria, and moving towards clinical trials, which I'll show you next, for using iodine, just painting it on the teeth, to try to shift the oral microbiome away from a cavity-causing population. And so overall, there's been an association with iodine to less cavities that was first noticed in the 1920s. It was summarized in the grade. There was this maybe most important cavity research paper in the 20th century was this National Research Council report on all the research that had been done from the 1800s to 52. About it. It's been used clinically in the mouth since the 1960s, usually as a pre-surgery scrub before extraction. But like I said, about 50 years ago, they started looking and saw that it killed strep mutans faster than other non-cavity causing streptococci. And that it killed strep mutans at a lower concentration than periobugs, or sorry, not periobugs, other commensal bacteria that aren't strep. Some of you may know that since the 1990s, many hygienists have been using iodine in their ultrasonic scalar troughs, like a 1-to-1 or further diluted, because of its effect on periodontal disease. It has been demonstrated that it specifically blocks the way that strep mutans turns sucrose into sticky plaque, into extracellular polysaccharide, by blocking glucosal transferase. And it does so more than fructosal transferase, whatever. But it has a specific mechanism that blocks plaque formation by strep mutans. There's been animal studies that show that it works in combination with fluoride, so that you can add that effect, which does prove out in the clinical trials. And there was quite a bit, you can see 74, 79, 1980, 1993, there's been quite a bit of this clinical microbiology looking at the levels of strep mutans before, immediately after, a week after, month after, whatever, out to 6 months, a year after iodine application. And what we see is that it comes up to about 1/3 of its initial level by 6 months. But at 3 months, it's really suppressed, maybe 10% at most. It's totally gone for a week. And then in some patients, it slowly comes back and creeps up back to about 1/3. And some patients that eliminate strep mutans long term. But that's sort of the story, is that it lasts fully 3 months, maybe still has an effect at 6 months. And so based on this microbiology, this clinical microbiology, clinical trials have been done using that every 3 months or every 4 months as the frequency of iodine application. So if any of you have ever seen a forest plot before, bravo. If you haven't, I hear you. So what this is each of these different lines, each of these different squares and lines around them is a different clinical trial and its statistical summary, where if the line overlaps this line of no difference, then we don't have a statistically significant difference. But looking across these relatively small clinical trials, what we see is that there is almost a statistically significant effect, and a pretty large one. that is on decreasing the number of people with cavities. And so if you include these relatively large cohort studies that have been done, where they took kindergarteners who didn't have iodine, they went forward, became first graders and second graders, and then each year afterwards they added iodine and they compared what happened over time. Then together you have a very statistically significant effect, and it seems to decrease the number of children who get cavities at all by about 40%, which is really impressive. If you look across, there's the details if you want them. If you look across background of fluoride, it seems to have a greater effect with having fluoride than I'm sorry, the other way around. It seems to still have an effect on top of fluoride, and it seems to have, in patients that have no fluoride whatsoever, it seems to have a greater effect. And across everyone, the big thing that we learned is that there's these 2 clinical trials that applied iodine just for a month, either just once or every week for a month, and then never again, and looked a year later, 2 years later. Those studies did not have an effect. If you take them out, you have a large statistically significant difference, no matter what you do. So continuing to apply every 2, 3, or 4 months, you get a really big effect. Just in the interest of time, I'll say that there is some myth about safety considerations. The allergy with seafood is a total myth. You can look it up. It's just one of those medical myths that's been propagated against all the data. There have been studies where people use 5% rinses every day for 6 months and doesn't change anything about their thyroid or other health outcomes. It's used for children. It's used to prevent and treat mucositis in children who are undergoing bone marrow transplant and get severe oral mucositis. So if it's used in those kids, it can be used in just about anyone. And again, it's commonly used as ultrasonic irrigant. So in general, it's extremely safe. And of course, there are some safety considerations if you actually have a real iodine allergy, for example, or you have a severely dysfunctional thyroid, then be careful. But these people know that. So literally, I'm talking about, drying a little bit, putting iodine on, and then if you like, putting fluoride varnish on immediately afterwards. So this is a present way that we all have in our medicine cabinets that some of us were using to prevent COVID spread in our clinics. And that works to shift the oral microbiome. And I love this from a pediatrician who's now doing this in many of her projects. If parents can brush their teeth, they can place iodine too. And so this is what I have done as a core preventive for my kids. So we talked about things that can actually change the microbiome and change caries outcomes in patients. And this is kind of the list that we have right now. I didn't talk about silver fluoride because I've talked about it so many places, so many times. I didn't want to annoy you. But with that, I'll stop babbling. I will thank you for your patience and your time. And I hope to see you in the coming minutes. Here's my email for questions and answers and comments and all that.
Thank you, Dr. Horst. Just as before, I'm going to invite anyone with questions up to the podium to ask those directly to Dr. Horst.
This is not moonshine, I swear.
Hi, my name is Lisa Bosch. I'm a dentist, and I graduated in 2019. I got my master's, and my practicum that I did was on maternal bacterial load and how that correlates with caries. And so my thesis was a little bit different, where I talked about kind of a family approach to oral hygiene and diet as well, but I kind of focused more on lowering the bacterial load of mothers. And so I wanted to ask if you had any insights as a pediatric dentist on, I've had a lot of parents, mothers in particular, that say, I want, all of my kids to get taken care of and then I'll take care of me. Or when we have kids come in and they have a bunch of cavities, then we are talking about how to brush their teeth. We don't talk to the moms about how to take care of their teeth and look at them and ask what's going on in their mouths. And then also how they typically have multiple children. And so by changing that bacterial load of the mother, how that can affect multiple children and what a huge impact that could be. It's kind of a separate issue from, the science of, the microbiome, but I wanted to know if you had any thoughts on that.
Absolutely. Bravo.
I'll let you
And
answer
thank
that
you.
one. I have one other one.
Okay, doctor. Thank you so much for sharing your work. And I'll say that there's some really beautiful clinical trials that some of the state Medicaid agencies have done, where they added coverage, full dental coverage for mothers during pregnancy and for the first 2 years after birth, that showed dramatic improvements in the oral health of their children. So less cavities in children by just providing dental coverage for the mothers, just like what you're saying. So there was a study in San Diego, kind of in the barrio there with a high caries population, where they used chlorhexidine and fluoride varnish and oral health instructions for expectant and new mothers, and that did not have any effect, unfortunately, on the outcomes. So I think we need to be careful about exactly what we do. But it's been shown that just treating all the cavities in a new mother prevents cavities in her children. It's been shown that her just simply chewing xylitol gum a few times a day, chewing xylitol gum a few times a day is a lot. So that's going to work for some people. It's not going to work for some people, but it'll work for some people. So especially if they're inspired by that story that it's 75% less cavities in their kids. So like you said, some mothers are going to focus on caring for their kids first. Some mothers are going to be okay with xylitol gum. Some mothers are going to be, really interested in just oral hygiene at home, constantly brushing, flossing their teeth, and hopefully improving the diet along the way. So I think these are all different tools, and the principle, like you said, the principle is the most important part that really works so well.
Thank you for that. The other question that I had is for the geriatric population, that how can some of this work that you've discussed with the microbiome and saliva affect the geriatric population that has a reduction of saliva, and that's the issue?
Thank you for that question. We have a sort of a national collaboration of hygienists who go out to nursing homes and face these issues every day. And to our surprise, what we resolved as the most important thing that can be done for older adults who have, salivary dysfunction, xerostomia, the number one thing that everyone agreed on was more water. That the nursing aides and caregivers just provide more water to these elders, and that the salivary function will come, that the clearance of the plaque, the clearance of the carbohydrates and sugars will come, that people will do better, they'll be hydrated. So that's just, it's one of those simple things that seems too simple to be a real answer, but it's a real answer. It can be so hard to get the caregivers to brush the teeth in nursing homes. And yet we have older adults at home brushing their teeth every day. So I think, again, there's different solutions for different people, but hydration is a fundamental issue. Vitamin D seems to be a super drug that in the decades before vitamin D was supplemented and everything, they actually did clinical trials supplementing vitamin D, and there were like 50% less cavities. The specific mechanism is the saliva. It improves the health of the salivary glands and the production of saliva, the quality and quantity. So, supplementing vitamin D in older adults, if you get it in because of their joints, you'll get it out in their teeth and their saliva. So there's specific mechanisms of saliva function that are as simple as water and vitamin D. That'll take us a long way. And then in terms of the antimicrobials or prebiotics, the first step in managing caries in an older adult, especially root caries for a lot of people now, is using silver diamine fluoride. It's a profound preventive in root surfaces. It's a profound treatment in root surfaces. And absolutely, we might, go back and do restorations on top of that. But it's the most effective, most efficient tool that we have right now to control the way the bacteria go into the roots and cause such problems in older adults, especially when there's hyposalivation. The iodine can be used. So this is something we're really interested in. You know, nursing assistants, all the nursing homes, they have iodine. You know, a lot of older adults grew up with putting iodine on wounds. They can put it on their teeth, you know, 3 to 6 times a year, and they will get less cavities. So thanks for the prompt.
Thank you. Yes, thank you very much.
Thank you, doctor.
Hi, doctor. Thank you so much for the information. And a person with celiac disease, anything about microbiome is important for me. So I appreciate you just bringing up the oral microbiome. My question is, I'm Tony Meyercord. I am a clinical dental hygienist and adjunct faculty at one of the community colleges in the St. Louis area. My question is, we were talking about arginine a little bit, and the population of patients that I serve in St. Louis County, the average age is about 60, so dry mouth is an issue. One of the things that I was curious about is, have you done any research on the basic bites, which also have arginine in them, and if that is potentially an opportunity to kind of get saturated into nursing homes and things like that. Anne Guion introduced many hygienists years ago to the wonders of arginine and things like that. I don't know if you know her. She kind of knows you a little bit too. But I was just curious. Anne Guion, yeah. So anyway, I was just curious about the basic bites and if you've done anything with that.
I love that basic bites. That's a great call out. So first of all, any sugar-free chewing gum will prevent caries by getting the saliva flowing.
Mm-hmm.
If we were in person, we would have done a hands-on where we measure our pH with, you know, our salivary pH, and then we chew some gum and measure our salivary pH. And sort of the moral of that story, or the surprise of that story, is that even sugar gum momentarily raises your pH in your mouth because it melts the saliva glands. So that's another thing that we can and should be doing. And basic bites, you know, just like the xylitol gum, it has 2 mechanisms. So the basic bites uses arginine. I haven't seen any clinical trials on basic bites, but it should work. I mean, everything with arginine thus far, you know, has worked. Everything with non-sugar gum has worked. So, you know, I think we can safely assume that basic bites will be a great help to xerostomach and really any aspect of the caries, of people with caries. Yeah, so, you know, maybe if you're using it in your population, your faculty member, you know, grab a student and publish it. You know, what's the rate of cavities before you start doing this, and a couple of years after? Does it make an impact? What's the, even just a correlation of what we see is it should be out there in the literature, because it's a really smart tool. It's a really smart tool, and I think it's brought to us by dental folks, right? Yeah, right on.
Thank you.
Absolutely.
Thank you very much.
Thank you.
Hello.
Hello.
So I'm Dr. Dumble. I'm a dentist in the Kansas City area at a community health center, and I'm currently in the process of developing a prenatal oral health program. And so I appreciate your mention of xylitol gum, because that's not something I thought to integrate into that for new moms. And with that, how do you improve compliance? Because with actually using the xylitol gum, when do you provide the xylitol gum? How much should you give them to prescribe? Stuff like that to make sure it's actually successful.
Rock on. So compliance is something, it's like the reason that we're, you know, doctors and hygienists. It's like, there's no one can make up for the human factor that is our clinical reality. And so I think you probably know your community and what motivates them better than anyone. And I think, you know, as clinicians, that's really the part where we're always going to need a clinician in the loop, no matter where the technology goes, because compliance, like, how do you get people to actually do these things in a practical way that works for them? Can you give them a set of options that they could choose from, like a little menu? Certainly the technique of motivational interviewing has shown just in itself to prevent cavities. It's hard. I'm still learning, and I've been learning it for 8 years now. If anyone's seen the video, what's the nail? It's not about the nail. There's this great little skit that's like 2.5 minutes. Anyway, The point is that I think listening to our patients and hearing what works for them and what doesn't helps us to provide options that would work for them, that are realistic. I ardently believe in showing the data. So I showed the data to all of you because I don't think you have any real fundamental reason to trust what I say or a written line. But if you see the data, the published data itself, that tells a story that I think is convincing. Or if it's not convincing, then, you know, when I was in residency for pediatric dentistry, one of our faculty members, who's a very famous cavity researcher, said that fluoride toothpaste prevents 70% of cavities. You can bet the next month, everybody I talked to was starting in on fluoride toothpaste. Then I looked for the data myself and I saw that it's 22%. So fluoride toothpaste used every day versus non-fluoride toothpaste prevents 22%. That's a really different story. So, you know, shame on him, shame on me, whatever, we figured it out, it's all good. But the issue, the opportunity there is to take the slides that I've shared with the meeting organizers, pull that out, ask me for the primary paper, whatever you want, but to show the actual data to people when your kid could have 75% less cavities by you chewing gum for a year. Is that motivating for you? If they get 4 cavities when they're 2, they're going to get sedated and put under general anesthesia or whatever the story is, not to scare them too much, but to also share the reality to empower them. So I think there's a combination of talking and listening, training the dental assistants or whoever's having that conversation to show the data and understand it at a level that's functional, and for folks to understand the risks there.
Thank you.
Right on. Thank you, Doc. That was funny.
Hi, my name is Maya Grant, and
Hi, Maya.
I became a doctor when I drank Dr. Pepper at the age of 2. But also, my question is, being the germaphobe that I am, I don't let my siblings have anything. Also because they have backwash, but that's besides the point. Is there like a sibling relationship that would like have to do with like, you know?
There is, absolutely, Maya. Thank you for that wonderful question. So there's been lots of studies showing that this bad bacteria that causes cavities, the strep mutans, goes about half of it on average across the population goes from mother to child, because usually that's the person who's around the child most during this key period of their development. But of course, in other families, it's the dad, it's the grandpa, it's the auntie, whoever it is. So whoever's around them the most, sometimes the older sister, gives the bacteria that they end up with. So everything that you do to put down the Dr. Pepper, everything that you do to brush your teeth with fluoride toothpaste, everything that you do to eat healthy foods that your great-grandparents would have eaten, helps to support the health of your younger siblings. And if you haven't ever had a cavity, then please, Maya, take your plaque and put it all over your brothers and sisters.
Thank you, but I think I'm good. I think they'll pay me after that.
Do we have any other questions in the room? Okay. Thank you, Dr. Horsch, for a fabulous presentation. Thank you.